morning. This lecture video is going to go over the fluid compartments, or the different places where fluid and solutes sit into our body or are found in our body, and it corresponds to the fluid and electrolyte lab packet for advanced A&P. So the first thing we need to do is figure out where fluid sits in our body, right? So there are two general compartments that are found in our body. So the total amount of body water ranges from about 55 to 60% if you're a male, and about 45 to 50% if you're a healthy young female. Of this amount, about 2/3, so roughly 63% of the fluid is found inside of our cells, and we call this intracellular fluid. The remaining 1/3, or 37%, is found outside of the cell, extracellular fluid, also known as ECF. So ECF is going to be further divided into three components, really only two main ones. We have the interstitial fluid, which is about 3/4%, and we have plasma. So plasma is going to include the plasma and the formed elements, the red blood cells, white blood cells, and that makes up about 1/4 of the extracellular fluid. And then there are some smaller compartments within our body, like in our lymph, in the serous membranes, that serous cavity, your cerebrospinal fluid, those types of things where water will also sit, but they play a very minor role. So really we're going to be focusing on the intracellular component, and then the interstitial and the plasma components, and how much of those contain water. There are, not only is there water in these compartments, but there are also solutes or chemicals. So the solute that predominates or makes up most of the intracellular fluid includes potassium, intracellular proteins, hydrogen phosphates, and magnesium. Those are kind of the big ones. The solutes that make up our interstitial fluid is going to include sodium, chloride, bicarbonate, and then calcium ions. And then in our plasma, we really kind of focus on albumin, and it's an example of a plasma protein, but they're going to play a role in terms of solute concentration within the plasma as well. The amount of water and the amount of solutes in any of the different compartments, intracellular, extracellular, interstitial, plasma, those are going to drive the movement of water and solutes from one compartment to another. So it's an important thing for us to be able to look at and analyze how much water is going to be, water and solutes there are in the different compartments. So talking specifically about water movement. So water moves freely and continuously from one compartment to another by crossing membranes, cellular membranes. Water moves very passively. Okay, so it's a passive transport. Osmosis, we talked about that way back at the beginning of the semester. Osmosis is the movement of water from high concentration to low. It's a natural process, and it doesn't require any energy. It is influenced by two forces: hydrostatic pressure, which is going to be a push motion, so it'll push water, and then colloid osmotic pressure, which is going to pull water. So conditions that shift the balance of these different forces will result in a net fluid or water shift from one compartment to another. So the relative volume of water in the different compartments and the associated anatomy of the compartments is going to affect the hydrostatic pressure. The solute to water ratio in the compartments affects the osmotic pressure. Hydrostatic pressure, like I mentioned, is a pushing pressure. The more hydrostatic pressure in the compartment, the more push of the fluid. And osmotic pressure is a pulling pressure, so the more solute to water in the compartments, the more pulling on the pressure. So talking about water moving, water is going to move from either the ICF to and from the ECF, and that typically will be through osmosis. It will move from the blood or the plasma to the interstitial fluid, okay, and that's usually done by filtration or the hydrostatic pressure. It can move from the interstitial fluid to the blood or plasma. That's going to be caused by the colloid osmotic pressure, or it can move from the interstitial fluid to the lymph, and that would be interstitial hydrostatic pressure that causes that. So we're going to talk about each one of these real quickly. So the movement of water from the ICF to the ICF and vice versa. This is going to be done through osmosis. So remember that osmosis is the movement of water from high concentration to low concentration. If you have a high, this is going to be driven not only by the concentration of water, but you also have to look at the concentration of solute. So if you have two solutions, you have 10 milliliters of two solutions. So you got 10 milliliter beaker A, you got 10 milliliter beaker B, and let's just focus on salt. If you have a whole bunch of salt molecules in beaker A, that means you have less water molecules, right? If you have less salt molecules in beaker B, then you're going to have more water molecules. So solutes concentration and water concentration are always kind of going to be opposite. So the solutes that are in a compartment will pull water. So if the solute concentration inside the cell, so intercellular fluid, is greater than the solute concentration in the interstitial fluid, water will be pulled into the cell. And vice versa. If the solute concentration in the interstitial fluid is greater than the solute concentration in the cell, water will be pulled out of the cell. So think about water. It will always be going from a high concentration to a low concentration, and you can tell that by looking at by the number of solutes that exist in that water. So that's how water moves from ICF to ECF. It's passive, doesn't require energy, and it's just going to be driven by the difference in concentration of water. Water moving from an area of high concentration to an area of low concentration. So let's talk about water movement between blood and the interstitial fluid. So both of these are extracellular fluids, right? The plasma and the interstitial fluid, but they travel back and forth between the two. So water will move out of capillaries because the blood pressure, which is the hydrostatic pressure, pushes on the inside of the vessel walls. So because that pressure on the capillary walls gets higher, it will push the water out. Now, going from interstitial fluid to blood, water moves into the capillaries because the presence of the plasma protein creates a lower concentration of water in the capillaries, and then again, that's going to cause water to be pulled inside. So we're looking at, again, same philosophy as last time. Water is going to go from high concentration to low, but the solute that's going to drive that is actually the plasma proteins, that albumin. So that's how blood will move from the plasma to the interstitial fluid and then back again. So remember, these will be found, the blood or the plasma will be found in the capillaries, so the water's got to be going across those capillary walls. So it will be pushed out by blood pressure, or it will be pulled in because of the differences in solute concentration and water concentration on both sides. So the movement of water between the interstitial fluid and the lymph, so that was that tiny little leftover compartment after we talked about the fluid that existed in the interstitial fluid and then the plasma, there was a little bit left in the lymph. So most water that leaves the capillaries will leave due to blood hydrostatic pressure, and it will return to the capillaries because of the plasma colloid osmotic pressure. Water that is not returned to the capillaries contributes to the interstitial fluid hydrostatic pressure, which is going to push on the lymph and then pushing water into the lymph system. So it works kind of the same way as when we talked about water moving in the other activities or the other examples. It's just going to have to do with the pressure. So that's the movement of water. Let's talk about the movement of solutes. Between the ICF and the ECF, solutes are going to move passively through diffusion. So nonpolar lipid soluble substances will move through diffusion, just going from high concentration to low across the membranes. No big deal, pretty easy, doesn't require energy. Some polar substances and water-soluble substances can also diffuse, but they have to go through those specified channels in order to get through the membrane. So again, it's still passive, it's still considered diffusion, but you have to have the channels that exist in order to get them through. Proteins are too large to pass through the plasma membrane, so they kind of remained trapped within the compartment that they're in, and because they're trapped in there, they're going to exert a colloid osmotic pressure. And then really big substances and substances like the sodium potassium pump, we talked about that, calcium and chloride pumps. These are going to also be able to move across the membrane, but they require active transport. So they're going to require the input of energy in order to pump those things across the membrane, the cellular membrane. So this is, again, movement of solutes across the cellular membrane. Movement of solutes between plasma and interstitial fluid is going to be passive transport. So again, simple diffusion going from high concentration to low, although sometimes there are obstacles to this diffusion, and that could be the charge of a solute, the size of the solute, or whether or not there's a carrier molecule available to carry the solute. So solute movement is always, not always, but the vast majority of solute movement is passive. It's diffusion, high concentration to low. If you want to go opposite that, from low concentration to high, then you would rely on pumping systems, which would involve active transport. So let's look at laboratory assessment and control mechanisms. So laboratory examinations can be conducted to evaluate a patient's solute to water ratio and to look specifically at electrolyte levels. So the electrolyte levels that we typically would analyze would be the amount of sodium, potassium, calcium, chloride, or bicarbonate ions that would exist. So two essentially different tests looking at how much solutes are present and then what solutes are present. So if we're looking at serum osmolality, so a clinical assessment of an individual's serum osmolality allows one to evaluate the relative solute to water ratio in the extracellular compartment. So remember that osmolality refers to the number of individual solute particles that exist in 1 kilogram of water. Osmolarity reflects the ability to cause osmosis. So two terms that sound alike but mean different things. In a normal range, we have about 285 to 300 milliosmoles per kilogram. That's what's considered normal. If you have lower than that, what that indicates is that there's an inadequate level of solutes, or you could be having fluid overload. And what happens is that the water starts to shift then from the ECF to the ICF, from the extracellular fluid to the intercellular fluid. So water will start to rush into the cell. This also is going to inhibit the release of ADH, which you will be talking about during lecture, and that's going to cause the loss of body water by our kidneys. If this level is too high, what's going to happen is that it indicates that there's elevated solute levels or very low water levels, like in the case of dehydration. And then this situation will cause water to shift from the intercellular fluid, from inside the cell to outside the cell, causing the cell to crenate or shrink. Control of osmolality is through feedback mechanisms that are triggered by hormones that are acting on the nephrons. So specifically looking at the hormone ADH, which you'll kind of talk about in your lecture videos this week. So looking at assessing serum electrolytes then, these are going to be looking specifically at the amount of solutes that are present. So potassium levels are normally range from 3.5 to 5.5 milliequivalents per liter. So hypokalemia refers to a below normal potassium, while hyperkalemia refers to potassium levels that are above normal. Abnormal levels of potassium can affect the resting potentials of nervous and cardiac muscle tissue. So we don't want those to be disrupted. So we need to make sure our potassium levels are within that normal range. Sodium levels range from 135 to 145. And hyponatremia is abnormally low sodium. Hypernatremia is elevated sodium. And because we're talking about extracellular ions, abnormal levels of sodium most significantly influence the movement of water across the cell membrane. So this is going to determine whether or not water is rushing into the cell or water is rushing out of the cell. Calcium levels range from 4.5 to 5.2 milliequivalents per liter. Low extracellular calcium or hypocalcemia is low calcium levels. Hypercalcemia is high. And then abnormal calcium levels can impact synaptic transmissions, so the passage of that impulse from one neuron to another. It can also affect the force of muscle contractions. Calcium reabsorption in the nephron and from the bone can increase calcium absorption from the intestines. So calcium levels can also be monitored by hormones, and we can get calcium if we have hypocalcemia. We can pull that calcium out from our bone reserves. Chloride levels are most closely aligned with the sodium level, so they'll range from 95 to 105 milliequivalents per liter. Hypochloremia, low calcium. Hyperchloremia is high. And then there are actually, we can measure it, but there are very few medical conditions that are really directly related to high or low chlorine levels. Like I said earlier, we would most likely look then, if you had an abnormal chloride level, you most likely have an abnormal sodium level as well. So hormonal mechanisms, negative feedback, these are all going to regulate how much of these ions are in our body and then adjust to either high or low levels. So very much controlled by hormones. Aldosterone is going to promote the reabsorption of sodium and the secretion of potassium. Atrial natriuretic hormone from the heart promotes sodium secretion. Parathyroid is going to affect calcium levels. So many of these levels will be monitored and then responded to using hormones.